Good morning. Morning. Delegate Rodney Willett here for your morning wake-up call for your HHS triple hitter if you're going to do all three of our meetings here. Really appreciate everyone coming out. I know it is early, but these are super important bills, and we're going to go right into that. But again, I'd really a lot of familiar faces in the room, and I know we've done a lot of work in the off season to get to this point with these bills, and so thank you for all your support. With that, we're going to call the roll. Excellent, and we got a quorum. Very good. Okay, this is also the time of the year where we are juggling things, and one of our colleagues is juggling this morning several presentations. So we're going to ask Delegate Seabolt to first present her bill. Come on up.
Good morning, Mr. Chair. And good morning to the members of the committee as well. HB 1893 mixed recovery residences, which are a critical component of addiction treatment, reimbursable under Virginia's Medicaid program, expanding access to care for individuals with substance use disorder. The American Society for Addiction Medicine classifies recovery housing as a vital level of care and has updated its national standard Medicaid reimbursement criteria to include recovery residences, a criteria that Virginia and states across the country have historically recognized and adopted. Currently, many Virginians face barriers to accessing recovery housing, but this legislation increases accessibility while ensuring residences meet ASAM's high standards of care. This is also a smart financial decision. For every dollar spent on addiction services, the Commonwealth saves at least $7 in criminal justice costs and $4 in health care costs. Recovery residences help reduce substance use recurrence, saving money on readmissions and reincarceration. Additionally, the bill convenes a work group to assess the effectiveness and economic impact of recovery residences with a report due to the General Assembly by November 1st, 2025. This legislation saves lives, and I hope that you support it.
Thank you so much for explaining that. I'm going to start with any questions for the patron from the committee. Oh, and we've got one right here. Delegate Sickles.
Just, Delegate Seabolt, can you tell us what a typical commercial insurance policy might cover, like one of our fully insured plans in Virginia, or for a self-insured company? What would they cover?
Chairman Willett, to answer the delegate's question, I would love if I can call up the experts behind me who work in recovery residences to answer those questions.
That would be great, please.
Yeah. Thank you.
Okay. Yeah.
Good morning, members of the committee. Delegate Sickles, to answer your question, sir, currently under commercial insurance plan, non-Medicaid plans, they don't cover any recovery residences currently. And Medicaid has only covered recovery residences under what's been known as an 1115 Medicaid waiver, which many states have utilized. Yep. Although currently through the CMS system at the federal level, there is a bill that is introducing a housing SKU in alignment with the ASAM 4th edition criteria to create the reimbursable mechanism under the Medicaid system.
Mr. Chairman.
Yes, please.
So, Mr. Chairman, so CMS is considering approving this benefit now, and you just want to be prepared for us to take advantage of it when they say it's a benefit?
Yes, sir. Delegate Sickles, Virginia has been looked at as a national leader in recovery residences, community-based systems of care, and how they collaborate and work with licensed treatment facilities. And under the new criteria, what we're trying to do is keep Virginia leading the way in this field, which is creating reimbursable mechanisms to create accessibility, because currently recovery residences aren't reimbursed by Medicaid, and it's a private pay system. For such a vital component of care for individuals suffering from substance use disorder, we need a mechanism for long-term support.
Mr. Chairman, follow. What does the state employee plan cover? Do they cover this? The state that we provide for our own employees?
No, sir.
We don't have it either. Okay.
No, sir.
Okay, thanks. Thank you.
Any other questions from the committee? Yes, Delegate Scott.
Thank you, Mr. Chairman. Question for the patron. The question that I have is, what is the fiscal impact of this? I know it's for a work group, and I didn't see one online attached to this, and so I'm just wondering if there would be a fiscal impact creating a work group, and if the appropriate motion for this bill would be to report and refer to appropriations.
Wait, yeah.
Chair Willett, at this time, I don't see a fiscal impact as well.
I had not seen one on this. I think we're actually. They are? Oh, okay. Well, then we will send it to. We'll refer it if we need to. Okay. Good question. Good question. Any other questions from the committee? I know we've got a few folks. Well, we'll see what we have in the room, but maybe we'll start with any folks in the room who are in support of the legislation. And we are on a tight schedule. So I would say probably just a minute each if you even need a minute. Thank you.
Oh, absolutely. I'll be brief. Thank you, Mr. Chairman. I am Michael Silesmore, Advocacy Manager for the Substance Abuse and Addiction Recovery Alliance. We fully support this bill as it goes leaps and bounds to helping citizens who are suffering from substance use disorder become clean and contribute to a brighter future in the Commonwealth. And we have a lot more better experts after this. But
no, that's great. Thank you. Come on up.
Good morning, Mr. Chair and committee. My name is Sarah Scarborough, and I'm the director of Real Life. We're a recovery organization here in Richmond and have 11 recovery houses equaling 121 beds. I also serve as the chair of the board of directors for the Virginia Association of Recovery Residences. In both roles, I'm really excited about this legislation, as are many of the operators we work with across the Commonwealth. We believe it really represents a significant step forward for Virginia, and once again, highlights our leadership in this arena. As an operator, I see this as an absolutely essential move in addressing ongoing challenges posed by substance use disorder. Unfortunately, as we know, it does not seem like this issue is going away, and proactive measures like this are vital. At Real Life, we were founded to provide recovery housing to individuals who are completely indigent or lack financial resources and family support in order for them to access recovery housing. We are one of the few organizations that allow everyone to enter our housing for free, making sure that finances are not a burden. Over the last year, however, our costs have increased by 110%, so we have to subsidize a whole lot, which is just not a financially sustainable model. And exploring this would really help in this arena. Thank you.
So it's great to see you this morning. Thank you. You guys are doing amazing work.
Yes,
so
sir. Thank you.
Thank you.
Good morning, Mr. Chairman, members of the committee. Becky Bowers, I'm here on behalf of the Virginia Association of Addiction Professionals, and we are in support of this bill.
Thanks, Becky.
Good morning, Chair, members of the committee. My name is Steve Hammond. I represent VAR, Virginia Association of Recovery Residences, and I just wanted to echo everyone's statement and would appreciate this moving forward. Thank you.
That's great. Thank you. And looking to the audience, do we have anyone to speak in opposition to the legislation? All right, seeing no one there. I know we had a few folks sign up online, so let me go look to my list here. I think we're seeing, yeah, we're trying to see if this is. We had a couple names. We had Tom Jackson.
Yep, I'm here.
Yes, welcome.
Good morning, Mr. Chair, members of the committee. Thank you. My name is Tom Jackson. I'm the lead organizer of the Virginia Recovery Advocacy Project, organization dedicated to supporting the creation and funding of evidence-based solutions to the varying mental health and substance crisis we face. I'm also a person in long-term recovery from substance use and mental health challenges since 1991, registered peer specialist and authorized trainer of the next generation of peer specialists. As Tom Insel, the former director of National Institutes of Mental Health, wrote in his recent book, Healing, the fastest way to sustain recovery is finding the 3 Ps, people, place, and purpose. And the most significant part of place is a safe, evidence-based, recovery-friendly place to live. This is also evidenced by the fact that ASAM, the American Society of Addiction Medicine, did make recovery residences an officially supported solution to recovery in 2024. The hardest part for most people in early recovery, obviously, is paying for these, and this is a huge positive step in that direction, and we strongly support the bill. Thank you.
Mr. Jackson, yeah, thank you for joining us. I don't think we have anyone else online. Let's see this. Okay, good, we're good. And I don't think there's anyone opposed online. So with that, I just want to note and thank Delegate Scott. This actually was, that was on the list. I apologize. We did miss the referral. And so thank you for waking us up here. It is early. I'll just come back to the committee. Any further questions for the patron? Hearing none, we'll give you the last word.
I just thank the committee for the opportunity to present this bill.
Excellent.
Move to report and refer.
Second.
We have a motion to report and refer to appropriations. With that, we'll go on the board. And by a vote of 8-0, that is going to report, refer. Delegate Siebel, thank you so much.
Thank you. Thank you, members of the committee.
Okay. And I see Delegate Delaney in the front row, ready for us this morning. Come on up.
Good morning, Mr. Chair. Good morning, committee. I have HB 1731. So this bill is an update from my 2020 bill, HB 808, to reflect best practices, clarify the direction of the task force, and establish and ensure that necessary stakeholders are involved. So the task force that we established back in 2020 in my House Bill 808 was created with the intent to be a temporary fixture that addressed critical issues in the forensic nursing industry. However, it has resulted in a task force that I think is starting to live a little past its expected point of existence and has met its directive. And we need to make sure that, the professionals that are involved in that particular task force have the opportunity to get back to, other work that deals with, other pressing issues for forensic nurses. And so this bill, it sunsets the existing task force, but it does create a new temporary work group in its place, and that work group will be dedicated to finding sustainable funding for sexual assault medical forensic examiners and services in the Commonwealth. That group will present its findings to a report in the General Assembly November 1st, 2025, so that we can take a look and decide what might be some appropriate action to continue to expand access to forensic nursing here in the Commonwealth. The bill does also do a little bit of cleanup with some of the language just to bring it in line with other areas of the code.
That's great. Delegate Delaney, thank you so much for presenting that. We'll start with the committee and any questions for the patron. Not seeing any there. Do we have, I'll look to the audience, do we have anyone to speak in favor of the legislation?
Good morning, Mr. Chairman, members of the committee. My name is Davis Gammon with the Virginia Hospital and Healthcare Association, and we are in strong support of the bill when we thank the patron for not only carrying this legislation, but all of the work she has done to advocate on behalf of patients and providers who work every day to try to address sexual assault and domestic violence in the Commonwealth. As she mentioned, this is mostly a cleanup bill, but I think it could have really profound consequences in helping providers do their job, helping providers serve their patients who have experienced the most unspeakable trauma that we can imagine. Expanding these services and clarifying these services could really do a lot of good in communities across the Commonwealth. So again, we thank the delegate for carrying the bill, and we hope that it'll be the will of the committee to advance it to the full committee.
Great, thank you.
Good morning, Mr. Chairman, members of the committee. I'm Maura Holdren with Bon Secours Health System based here in Richmond and Hampton Roads. We want to thank the delegate for all of her work in this area and for bringing this bill. Bon Secours houses the largest forensic nursing program in the state, and we have had leaders involved in the task force, and we appreciate the work that has happened there and the advances that we've made for the state and for the field, and we look forward to the report of the work group to continue to enhance our work and our ability to provide this vital care in the communities that we serve. So we hope you will pass it. Thank you.
Excellent, thank you. Anyone speaking against the legislation? And I don't believe on this one we have anyone. Oh, actually, but Jennifer did sign it. I don't see Jennifer. We had one potential speaker, but I do not see. Oh, it's 30. I'm looking at the wrong one. No, we're good. We're good. No one had signed up there. With that, I'll come back to the committee one more time. Any questions for the patron? Otherwise, we operate by motion.
Move to report.
Second.
I have a motion to report, and it's seconded, and we'll go on the board. Excellent, and that motion carries by a vote of 8-0. Delegate Delaney, thank you very much for being here.
Thank you, Mr. Chair, and thank you, committee.
Okay. Excellent. We'll go. Yeah, we're going to take. We've got just going down in the order here. We have Delegate Gardner's Bill 1760, and we are doing a little bit more work on that with some questions on the cost side. So. I'd love to get a motion to take that by for the day, and we'll get it back in front of us next week.
So moved, Mr. Chair.
Second.
All in favor, say aye.
Aye.
Any opposed? No, great, and we'll get that back on the docket for next week. Okay, thank you. All right, we're going to go down to 1787. Delegate Orrock is going to make a quick venue change here, or location change. Look at that. Fleet of foot.
Good morning, Mr. Chairman, members of the subcommittee. House Bill 1787, as you may recall, last year I had legislation that was more narrowly drafted as it related to specific surgical informed consent procedures. As a result of that, it kind of came to my attention that we don't have any kind of a regular review process of any and all of those that are out there in the hospital community. And this just adds to the duties of the Secretary of Health that these would need to be reviewed at least every 5 years in toto, any and all surgical medical consent forms that are out there within the system, building some consistency within them from one facility to another, and as medical advances occur, make sure that they're up to date in the latest standards.
Delegate, thank you for that summary. I'm going to go to the committee first for questions, and we have Delegate Sickles.
Yeah, thank you. Delegate Orrock. So, you know, I've had to sign a few of these things over the years. Honestly, I probably don't read all the way through them. They put it in front of your face, and it's a piece of paper you sign. Do you think that these are changing a lot, that they change often, and because this is just in more government bureaucracy, if you ask me.
And Mr. Chairman, I guess that's kind of to the point. To my knowledge, there is no regular review. They just kind of languish out there until there is some kind of a legal issue that arises. If you remember the circumstances of last year that kind of precipitated that legislation, there was a very specific instance whereby the individual signed medical consent and a lot more was performed during the surgical procedure than that patient ever realized. That young lady behind that legislation of last year is here this morning to testify if the committee would allow her to speak to the specifics of her case, which led me to believe, and that I think we need to do it in a broader means, because if it affected in this particular surgical instance, it may very well in many others.
Thank you, Mr. Chairman.
Thank you. Just looking real quickly, any other questions from the committee? Delegate Orrock, if you've got someone to test, why don't we go right to your...
And Mr. Chairman, we do have Ms. Karen Collins from Caroline to speak to the specifics she dealt with in her life.
Yeah, come on up. Thank you.
Good morning, Mr. Chair and members of the committee. I will try to make it brief. I hope that given the nature of my story that you guys will allow me just a few extra minutes because it's a lot to fit into 1 minute. But I would just say, I would imagine that if I asked you, the majority of people would agree that when a person undergoes surgery, the expectation is that the only thing that will happen during the surgery is what was discussed with the doctor and agreed to on a consent form. That was certainly my understanding when I consented to a diagnostic laparoscopy and a possible appendectomy in 2018. Unfortunately, I learned the very hard way that is not the case. My doctor removed my only remaining and fully functioning ovary, the left ovary on the opposite side of from the appendix, Its removal immediately rendered me sterile, stripping me of the possibility of ever having another biological child, and thrust me into surgically induced menopause at the age of 37. It sentenced me to a life of misery as I struggle with the physical effects and emotional damage and robbed my family of the mother and wife I was prior to surgery. An oophorectomy wasn't on my consent form, it wasn't something I discussed with my doctor beforehand, and nothing in my medical record or the pathology report justified its removal. My doctor took something from my body without my permission, betrayed my trust, and violated his oath. What he did was wrong and it shouldn't have happened, yet it did. And though there was nothing I could do to get my ovary back, I took that misplaced trust and put it in our judicial system, hopeful that he would at least be held accountable for his actions. Much to my dismay, I found it extremely difficult to find a lawyer willing to take medical malpractice cases, and although I ultimately found representation, it wasn't before being told that it was just my ovary and that what happened to me wasn't traumatic enough to warrant a case. Even though ovaries are critical to women's health and overall quality of life and serve many functions beyond reproduction. Sadly, when my case went to trial, the jury found in the doctor's favor, and his winning defense was that he did not need my written consent for the oophorectomy because the fine print of my consent form stated that during the course of the surgery, unforeseen conditions may arise requiring additional procedures, and that I had authorized the doctor to perform those procedures if he deemed them in my best interest. Since that verdict, I have been determined to find a way to ensure that this doesn't happen to other women. That mission opened my eyes to the fact that what happened to me isn't as rare as it should be. I found countless stories online from women all over the country that have gone through similar. However, the most relevant is our recent Dr. Perez case in Chesapeake. He was one doctor with hundreds of victims here in Virginia who either had their reproductive organs removed without consent or were coerced into providing consent through lies and fear. The complaints that were filed for decades by his patients fell on deaf ears, and it wasn't until a nurse reported him to the federal government that he was held accountable. Also troubling is that about 200,000 oophorectomies and 600,000 hysterectomies are performed annually, but studies show that nearly 90% of them are either completely unnecessary or performed for benign conditions that could have been treated less invasively. Furthermore, the reports indicate that women in minority and economically disadvantaged populations are more likely to be victims of these unnecessary surgeries. As Delegate Orrock said, he proposed a bill last year that was more specific. I wish that it had passed. Unfortunately, it didn't. Its companion bill in the Senate passed with unanimous bipartisan support. For here today, I wish we were doing more, but I think at least this bill is a step in the right direction. And while I'm certainly not a proponent of the government interfering with medical decisions, women are in desperate need of protection from these unnecessary and harmful surgeries. Doctors should not be allowed to hide behind boilerplate fine print on consent forms. They should not have free rein on women's bodies based on what they deem to be in her best interest. The best interest for every woman is that she be afforded the opportunity to make her own decisions about what happens to her reproductive organs. Those decisions need to be informed, and they need to be in writing with no gray area. The only exception should be life-threatening circumstances. The driver behind this proposed bill is the epitome of my body, my choice, and continuing to ignore this threat to women's health only perpetuates the long-standing injustices women have suffered from flawed medical and judicial systems. I have an 11-year-old daughter, and I don't ever want her to hear that it was just an ovary.
Right.
Thank you for your time.
Thank you.
Thanks.
Thank you. And we've got a question from Delegate Gardner.
Oh, sorry. This is for the patron. I guess my question would be, how would the review mitigate the fine print on the consent forms?
Mr. Chairman, I would respond. In general, the premise behind this is our Secretary of Health is charged with the responsibility of ensuring the health and well-being of all of our citizens. And towards that end, just a review to make sure the language is clear enough, be understood that potentially there would be some guidelines requiring further explanation. The specific case that Ms. Collins dealt with was a circumstance whereby the physician that removed the ovary was assisting. He was not the primary surgeon in the case. Because of a history of endometriosis, he had asked if he could be in the room in case he saw something subsequent evaluations proved there was really no reason or history why he should have looked to the ovary on the other side. Specifically, the pathology didn't show post-op that there was any need for the removal. But Ms. Collins didn't anticipate in any way, shape, or form that her signing of an informed consent when something was medically necessary that they found when they went in was going to be as broad as, well, maybe this will be an issue, so while we're in here, I'm going to remove it.
Mr. Chair.
Yes, please.
Follow up. I still get back to, are we asking to remove that fine print or just review it? I'm trying to see how this legislation would mitigate those.
This would just ensure that the Secretary of Health, with the expertise he has among other medical professionals and stakeholders, would review it from the context of looking at it from the patient's perspective, but also providing the necessary language for the medical professionals to provide the care that will be needed at that juncture. It's just trying to strike that balance and make sure, my understanding, there is no specific review process out there. It's just kind of a, well, when something arises, we'll look at it.
Thank you, Mr. Chair.
Thank you. I'd love to get, if we got a couple of folks from the Hospital Association, maybe they could weigh in just to understand sort of the current state of if you could speak in general for how the hospitals are handling this. Thanks, Brett.
Morning, Mr. Chair. I'm Brett Rawlings, Virginia Hospital and Healthcare Association. So just first and foremost, we do not have a position on this legislation. In general, informed consent is about the form, but I think some of the questions you're asking get more to the conversation that happens. And then there's the circumstances that happen in the operating room, in the operating suite. And so I think as far as the getting to some of the conversation here where we are now in the form and review, I'm not aware of any current process by the Virginia Department of Health to review informed consent rules. Obviously, that's something that's regulated in the sense that failure to obtain adequate informed consent is an intentional tort battery that is subject to legal remedy. Also, we have accrediting agencies that are accrediting agencies and conditions of participation for Medicare and Medicaid participating hospitals that have certain rules and guidelines around informed consent. But to my knowledge, there is no formal review process that occurs on any regular cycle of forms used in hospital or physician practices. Happy to answer any questions.
Thank you. Brett, hold tight, if you don't mind, 1 second. I think we've got Delegate Sickles has a question, but we also have Delegate Herring.
Okay. Thank you, Mr. Vice Chair. I appreciate that. Just a quick question, just to refresh our memories on the definition of what a surgery is. A surgery. How is a surgery defined? Is it defined as an invasive procedure where flesh is cut? How? Just a simple definition.
Mr. Chair, Delegate Herring, I'm not aware of a uniform recognized definition of surgery, but yes, I would assume that the invasive nature of it would be what would be kind of the threshold question anytime you're incising or debriding. I don't even know. Frank, good question. Debriding a wound, and maybe others in the room know the answer to this question, but debriding a wound, on the surface without breaking through the skin, is that a surgical procedure? Probably yes. I don't know if that answers your question.
It does. Okay. Thank you so much.
Yes.
Now we'll go to Delegate Sickles.
Mr. Chairman.
Yes.
Thank you, Mr. Chairman. So, Brent, the fact situation that was presented to us, I think most people would say that is a clear tort situation, a clear med mal case. Why do you think no lawyers took that up? Was it because of the small print language that the trial attorneys looked at that and said, well, this is a free pass for the surgeons?
Yeah, Mr. Chair, Chairman Sickles, I can't speak to, I'm just thinking, in my head of a typical informed consent form and, describing the anticipated procedure, having some language recognizing that in the course of a surgical procedure, complications may arise, that additional procedures may be necessary depending on what you find when you get in there. I'm not aware of forms that have a question would be, is there a form that could say, under no circumstances do I agree to the following? I assume that there is a place to do that in a conversation between a physician and a patient. If the doctor says, when we get in there, we may find this, and if I find this, I might be inclined to do that. How do you feel about that? Here are the risks and benefits of doing that. And the patient says, under no circumstances shall you do that.
Mr. Chairman.
That would be a very clear answer. But direct answer to your question, Mr. Chair and Chairman Sickles, yes, it does sound like something that would definitely be at least amenable to a lawsuit under informed consent. And then it gets to what was the standard of care and all of the facts and pleadings around that. So it's not a surefire decision, but certainly the facts that arise would present medical malpractice.
So, Mr. Chairman.
Yes.
So if, the root cause here is that language that, catch-all language at the end. Would the hospital association be opposed to just eliminating that? That's really the issue here. It's not sending a form in for the governor to say, this catch-all phrase is too big. We need to limit the options for the doctor and the surgery.
Kind of speaking to my intent, if I may, Mr. Chairman.
Yes.
So, Delegate Sickles, I would say I hear your question. I think the question in the circumstance, Ms. Collins, was the broad nature of other procedures as deemed medically necessary.
I understand.
And if I may, Mr. Chairman, in speaking to the Uber chair, would I be correct in having a sense of where this measure as it currently exists is going?
Well,
I'm not seeing a positive vibe, shall we say, from the majority of my subcommittee members. Would that be an accurate assessment in the Uber chair's mind as well?
Mr. Chairman, I'm not really sure how. I didn't survey everybody up here, but to me, I don't think this solves the problem you're trying to solve. So I don't know if the problem is solvable.
So Mr. Chairman, if I may to pose a question to my Uber chair.
Please.
Would the Uber chair be amenable if he and I would continue a conversation off committee, let the measure go by for the day, and see if we can find some language which may be amenable or else an alternative means of addressing the issue?
As long as Mr. Rawlings is in the room with us.
The problem, I'm sorry. You said as long as Brent agrees, we got to get him too. Okay.
Mr. Rawlings and maybe Mr. Johnson over there. We'll pull him into it.
So, and I will say, Mr. Chairman, to that point, after last year's legislation, that's part of what precipitated this approach, was in speaking with those individuals. The problem with last year's, it was so focused in one particular area, and the concern was if there's a problem with our informed consent standards and language right now, it's not just reserved to that specific narrow area. Maybe we need to look at the whole thing. But if the Uber chair is amenable, I would ask for it to go by for the day, and we'll see what we can work out.
I think it's amenable to me. I think if we sent this bill like this to the governor, based on what he says in his speeches, he would veto this. Being more government, more regulation. But so we need to work on it. So I agree.
Yeah. I think the sense of the committee is let's give it one more shot here and try to work on it. So I'll take a motion to go by for the day.
So, Mr. Chair.
Second. We've got a motion second to go by for the day. All in favor, say aye. Aye. Any opposed? Okay, great. Thank you very much. That's a good discussion. We'll bring that back. I've got one other bill on the docket, which actually also needs to go by for the day, so we're loading up our agenda for next week, but that's okay. And that is HB 1877 from Delegate Carlson. A little bit more work required on that one as well. So I'd also like to take a motion for that to go by for the day, and we'll get it back next week. Second? Second. All in favor?
Aye.
Any opposed? No, thank you. With that, we are done for today. Really appreciate everyone coming out so early, and we will see, I think, most folks back here at 8:30 for the full committee. Thank you so much, and we are adjourned.